Thank you. And I want to thank Dr. Kaplan and NephCure for allowing me this opportunity to come and speak to some parents and families about this condition and our trial. And the purpose of the talk is to review with you what the NIH, NIDDK has so graciously allowed us to do, to have a clinical trial to see how best to treat children and young adults with this condition. And I must say I'm one of the 5 principal investigators, but there are many more players in this initiative. And about 5 years ago, with the help of Dr. Briggs and Dr. Marva Moxie-Mims, a number of investigators met at the NIH, and the founders of, co-founders of NephCure were there, and we had a workshop for 2 days to try and see how we could come to grips with this condition and how to come to a consensus of how best to treat it. And as you just heard, we really don't have a good consensus of how to treat it, but we did our best to put together some ideas for a trial that would be acceptable across the country. The idea was to come together with some cores of centers and participating sites that would cover North America. And we came up with 5 cores. There were a request, as Dr. Marva Moxie-Mims told you, about program announcements. There was an announcement in the NIH guide for a U01, which is a contract, and it asked for applications from around the country for investigators to put in proposals how best they would treat focal sclerosis. And of over, I think, 10 to 12 applications, 5 were chosen. And in those 5 applications that were chosen, they represented cores of which each major center had a host of maybe 20 or 30 participating institutions under their umbrella. So we formed a network across the country into Canada, including Mexico and Puerto Rico, to have sites that wanted to participate in a clinical trial. And shown here are some of the investigators. We have 5 cores: Stony Brook, University of North Carolina, St. Joseph's Hospital in Arizona, Montefiore in New York, and this is Seattle Children's Hospital. And the investigators at each site, their PIs and co-PIs, and at each site there are pediatric nephrologists and internal medicine nephrologists collaborating together to set up a structure, so to speak, an infrastructure, to reach out to the pediatric nephrology community and the internal medicine community to advertise this study. Organizations that also participated in this network that was forming were prior organizations that had centered on illnesses in children, one called NAPROTEX. It's a North American Pediatric Renal Transplant Coordinating Sites, and that's a database that you heard about the purpose and usefulness of databases. This had over 5,000 entries of children in North America with kidney disorders of varying kinds. There was also a Southwest Pediatric Nephrology Study Group, which had over 1,000 entries in their database, and he had used this database under Ron Hogg's direction to publish a series of articles on various conditions and in pediatrics. We had a database coming from the Mid-Atlantic region, from Baltimore up to New York, which also was useful in putting together a network. And there was a Western Society of Pediatric Nephrology. So I'd like to use this slide to show you that it is really a national unified effort to have people come together, investigators from across the country, to put their efforts into this condition. And this is where we are today. The number of sites has increased. Over 136 sites are participating in the study. We also had to form a critical component to this clinical trial involving our pathology colleagues, because as you saw in some of the speakers previously, what we call focal segmental glomerulosclerosis as a condition is really made on a histologic diagnosis. So having a very strong committee of renal pathology experts across the country associated with each core was very important to the study, and we were lucky to have a chair of this committee, Vivette Diagati, who's at Columbia Presbyterian, who's a world-renowned renal pathologist, and every one of these other pathologists have all contributed substantially to this group of working renal pathologists that give us really the expertise needed to standardize and validate criteria based on a biopsy for possible entry into the study. And they work together, even though they're separated by distance. If one has a slide that comes in to look at that they're not quite sure of, they will send it to another pathologist in the other core for confirmation. And they have meetings and conference calls, and they really do work together to give us a network of expertise that, without which we wouldn't have this trial. Now, the objective of the trial is as follows. It's a randomized trial, and it's a randomized trial to compare two treatment arms or two therapeutic interventions for patients aged 2 to 40 years of age. Originally, the age range was 2 to 35, and then after about a year of the trial, we increased the age to 40. And these patients have in common one thing, that they're resistant to steroid treatment, and they have a biopsy confirmation of primary idiopathic FSGS. Those are the criteria. We came to this objective after a long period of debate, looking at what are the factors that might be accountable for FSGS in a 2-year-old versus an adult. We know this is a very large, wide age group, and some of us would feel that what a 2-year-old has as causes of FSGS may be entirely different than what a 39-year-old has. But nevertheless, we made some compromises working with our colleagues in internal medicine to make this an inclusive study of young children and young adults. The goal initially was to enroll more patients. We've now leveled off to 200 patients to compare the two therapeutic interventions, and most importantly, in addition to comparing therapeutic arms, to facilitate the investigation of this complex pathobiology, pathophysiology of what we call FSGS. Because inherent in this study, aside from the comparing some treatment arms, we are also going to be able to accumulate samples and in a repository for future, current and future investigation into the causes of FSGS. I'll talk more about that later. We had to come up with some inclusion criteria, and I will tell you this was my first experience with a clinical trial. I had done a lot of work in the lab before this, and I thought that clinical work would be pretty easy. Well, I was mistaken. A clinical trial is an intense effort involving a review of the world's experience, world's literature, meta-analysis of existing data on treatments, and trying to come to grips with an area that has still no consensus for treatment. And also kept in mind here is the safety of what we're doing. So we have the inclusion of an age limit of 2 to 40 years of age at the onset of the proteinuria. The patient has to be less than 40, obviously, at the time of randomization. The reason we chose 2 as the initial age group is that patients who present under 2 may have other causes of nephrotic syndrome and steroid-resistant nephrotic syndrome other than FSGS. And there we're talking about some of the genetic causes, such as congenital nephrotic syndrome and a few of the variants, and that's not considered FSGS. They have to have a kidney function that's greater than what we put here in terms of mLs per minute per 1.73 meters square, greater than 40 mLs. And what this equals really is someone who has function that's almost 50% of normal or better. The rationale here is that as the kidney function, as an estimated glomerular filtration rate, would drop below 40% of function, we would have difficulty showing efficacy of a treatment in that patient in either reversing the proteinuria into a remission or preventing further progression of the kidney disease. And then another criteria here is the simple first morning urine for protein and creatinine ratio greater than 1. Initially, the criteria was a ratio greater than 2. We dropped it to 1 to allow more eligibility for the study. This is the first morning urine, which you all know is something that your nephrologist asks to be obtained, and in some cases it's difficult, especially in the toddler, but we use this as a marker of proteinuria. And if the ratio is greater than 1 on 2 repeated urine analyses, then this is an entry criteria that is being met. Steroid resistance prior to the time of randomization, marked by failure to achieve a sustained urine protein creatinine ratio less than 1. And this steroid resistance will vary depending on the investigator's idea of how much steroid one should get. You've heard Dr. Connolly talk about it. You've heard Dr. Kaplan talk about it. And we felt that a minimum of 4 weeks of prednisone therapy, and that's usually at a high dose, with a cumulative minimal dose of 56 milligrams per kilogram or 1,680 milligrams or equivalent, would be adequate to say that the patient has received steroids but failed to respond. This would be equal to 2 milligrams per kilo per day for 4 weeks. In addition, some patients may have received intravenous doses of what we call pulse-methylprednisolone along the way, especially in adult populations, but also in many of our pediatric populations. And we felt we would have an unlimited number of doses of the intravenous pulse therapy, which would allow them to be included as well. So they can have failed the 40 weeks of steroids, and they have failed pulse-methylprednisolone therapies on repeated administration. And finally, we have to have the biopsy confirmation as primary FSGS, including all the different subtypes, as determined by a core's central renal pathologist. This is essential. We can't just take a biopsy report that comes as a fax. The renal pathologist at the core would actually get slides from the site that had a patient that they were considering to be entered. Those slides would be sent to the core pathologist for review. And within a 48-hour period, that result would be turned around to see if it was really primary FSGS. Who gets the study done? You approach a potential patient by having the investigator and the study coordinator speak to the family, usually while they're in an outpatient setting. And what we like to do is we give them the brochure about the trial, which is on the website for all of you to download. And we encourage that they read it and come back at a later date, not in the clinic setting, but meet privately with us. We're fortunate enough to have an office away from the hospital where they can sit down in a conference room, and we usually bring 2 or 3 families at one time and talk about the trial. We serve them some goodies, and we informally answer their questions in a very informal manner that takes away the pressure from being in a noisy clinic or hospital setting. And they've had some time to look at the protocol at least and the trial information. And sometimes they'll bring the child with them, but they may want to come without a small infant or child. And we want to advise them in advance that compliance is essential for the study. This cannot be done half-heartedly, as you know. This is the type of thing where they can't miss appointments, they can't miss medications. They have to really pay attention to compliance. If they don't, then the value of their contribution to the trial is significantly lessened. Blood work is drawn at every visit to ensure the patient's safety and determine the dose titrations. And when we looked at the number of times we draw blood, it's not that many more than you would normally do caring for your patients as you put them on a new agent. And after the screening visit and week 0, that's where the medication is dispensed, the visits become further apart and more towards a normal situation. We try and develop a good relationship with the patient. It's critically important, and the family, and they must be able to communicate to us easily if there's side effects or problems, really at a minute-by-minute basis, whether this involves calling the hospital operator, calling the office, calling the page. We encourage continual communication. We want to make sure that the patient and the family are part of this trial means that they are getting good treatment, the best treatment for the patient, and the best efforts to maintain safety while we try and learn about the best treatment for their children. Some of the helpful hints are appointment reminders. Luz will call the families well in advance to tell them you've got an appointment coming up. Also, we provide pill organizers to help them dispense the medications and let us know when they may be getting low. In the younger child, we use Emla cream for the patients who are hard blood sticks. We want them to be patient. We're very courteous with them, and we're available at any point in time for their needs. So that was what Luz was going to say. She's much prettier than I am, and she gets her message across, and without her there would be no success, at least at our core. Thank you.